Good morning, and welcome everyone to day 3 of our ACIP meeting. Today is June 23rd, and I'm pleased to call our ACIP meeting to order. We will just have a brief roll call this morning to ensure we have quorum. So I will tell my colleagues the pattern today, and we are going in alphabetical order. Ms. Bata.
Good morning, Lynn Bata, immunization clinical consultant at the Minnesota Department of Health, and I have no conflicts.
Thank you. Dr. Bell?
Beth Bell, clinical professor, Department of Global Health, University of Washington, no conflicts.
Thank you. Dr. Brooks?
Oliver Brooks, CMO, Watts Healthcare Corp., South Los Angeles, no conflicts.
Thank you. Dr. Chen?
Wilbur Chen, Professor of Medicine at the Center for Vaccine Development and Global Health, the University of Maryland School of Medicine. I have no conflicts.
Thank you. Dr. JYNNEOS?
Sybil JYNNEOS, Associate Professor of Medicine and Pediatrics at the Warren Alpert Medical School of Brown University, and I have no conflicts.
Thank you. Dr. Daly?
Matt Daly, Senior Investigator, Institute for Health Research, Kaiser Permanente, Colorado, no conflicts of interest.
Thank you. Dr. Cotton?
Good morning, Camille Cotton. I'm the Clinical Director of Transplant and Immunocompromised Host Infectious Diseases at Massachusetts General Hospital and Associate Professor at Harvard Medical School. I have a conflict, which is that I have worked with Takeda on a clinical research project involving cytomegalovirus, which has not involved vaccines in any way. Thank you.
Thank you. Dr. Lair?
Dr. Jamie Lair, Private Practice Family Medicine, Ithaca, New York. I have no conflicts.
Thank you. Dr. Long?
Good morning, Sarah Long, Professor of Pediatrics at Drexel University College of Medicine, practicing pediatric infectious disease doctor. I have no conflict.
Thank you. Ms. McNally?
Good morning, Veronica McNally, President of the Brainy Strong Foundation based in Michigan, and I have no conflicts.
Thank you. Dr. Paling?
Good morning, Kathy Paling. I'm Professor of Pediatrics and Epidemiology at Wake Forest School of Medicine, Atrium Health, Wake Forest Baptist. I have no conflict. Thank you.
Thank you. Dr. Sanchez?
Pablo Sanchez, I'm Professor of Pediatrics at The Ohio State University. I'm a neonatologist and pediatric infectious disease specialist at Nationwide Children's Hospital, Columbus, Ohio. I have no conflict. Thank you.
Thank you. Dr. Talbot?
Kip Talbot, Professor of Medicine and Health Policy, and I have Vanderbilt University Medical Center, and I have no conflicts.
Thank you. And this is Grace Lee, CQO at Stanford Medicine Children's Health, Professor of Pediatrics at Stanford University School of Medicine, and I have no conflicts. We are ready to open with the first session of the day, which is on monkeypox vaccines, and Dr. Pablo Sanchez, who is chair of the monkeypox vaccine work group, will provide an introduction and overview.
Thank you, Grace. First slide. So Mpox outbreaks before 2022 were rare outside of Africa. And in Africa, there have been 2 clades that have been involved. The clade 1, which was previously the Congo Basin clade, and then clade 2, which was the previously West African clade. In the United States, these outbreaks have involved clade 2. Clade 2A occurred back in 2003. There was an outbreak associated with pet prairie dogs. Clade 2 is the most recent one in 2022-23 global outbreak that was associated with male-to-male sexual contact. And historically, clade 1 is believed to be associated with more severe disease than clade 2. But next slide. But certainly severe manifestations have been associated with, have been seen with the current clade 2B that has been involved, that has been the cause of the 2022 and 2023 outbreak. As you can see here, these have involved, these severe infections like the ones here have involved severely immunocompromised individuals with severe HIV infection with extremely low CD4 counts. Next slide. So with global eradication of smallpox, routine vaccinations against orthopox viruses were no longer needed. And just as a reminder, routine smallpox vaccination stopped globally in 1980. In the United States, it was 1972. ACIP recommendations for persons at occupational risk for orthopox virus infections have been in place since 1980. And the largest proportion of people who have been recommended to be vaccinated have been research laboratorians who work with orthopox viruses, including monkeypox virus. The recommended vaccines have been ACAM 2000 and the JYNNEOS vaccine. Next slide. So the current ACIP recommendations for persons at risk for occupational exposure with respect to the use of the ACAM 2000 and the JYNNEOS vaccine have been published on MMWR. Since 2015, ACAM 2000 was recommended, but in November of 2021, the JYNNEOS vaccine was recommended as the alternative to ACAM 2000. Next slide. So just as a reminder, ACAM 2000 is a live replication-competent vaccinia virus, whereas the JYNNEOS vaccine is a live but replication-deficient vaccinia virus. And the JYNNEOS vaccine is given subcutaneously, 2 vaccine doses, 28 days apart. Unlike the ACAM 2000 that you can see here, there is a take. There's no take with respect to the JYNNEOS vaccine, no scar, and no risk of inadvertent inoculation and auto-inoculation with vaccinia viruses. Next slide. There, that's the take. Next slide. And so again, as a reminder, and what's made the JYNNEOS vaccine really the current vaccine that we're utilizing is because of the lack of contraindications for its use compared to the ACAM 2000. And really the only contraindication is a serious vaccine component allergy. Next slide. So with the current 2022-23 U.S. Mpox outbreaks, JYNNEOS was recommended, fewer contraindications and adverse events with JYNNEOS. And before this outbreak, though, there was no real-world experience with the JYNNEOS vaccine. Next slide. Currently, there's no ACIP recommendation for the use of the JYNNEOS vaccine during Mpox outbreaks. And so our goal is to develop ACIP recommendations for use of the JYNNEOS during Mpox outbreaks. And as a reminder, public health authorities determine whether there is an Mpox outbreak, and a single case may be considered an Mpox outbreak at the discretion of the public health authorities. Next slide. So at the February 2023 ACIP meeting, the vote was passed for the use of JYNNEOS during outbreaks. And ACIP, we recommended the 2-dose JYNNEOS vaccine series for persons aged 18 years and older at risk of Mpox during Mpox outbreak. Next slide. So in February 2023, as you can see, we recommended the use of 2-dose JYNNEOS vaccines for persons 18 years of age or greater. Today, we will be speaking about Mpox, the use of the 2-dose JYNNEOS vaccines during Mpox outbreaks in those less than 18 years of age, as well as updating about vaccine effectiveness and safety, with the goal in October of 2023 to consider the need for longer-term vaccination strategy for the 2-dose JYNNEOS vaccine. So the agenda for today's meeting, there will be an update about epidemiology, vaccine safety, and vaccine effectiveness during the ongoing outbreak, and this will be presented by Faisal Minhaj. There'll be Agam Rao will present on the clinical guidance about the use of 2-dose JYNNEOS subcutaneous series during Mpox outbreaks. And then she'll also present considerations for long-term protection against Mpox with discussion in the context of the ongoing outbreak. Next slide. So the tentative timeline for ACIP discussions and votes, just to remind everyone that the current United States Mpox vaccination strategy remains very active, and populations at high risk should continue to be vaccinated. And so today we'll discuss the clinical guidance about the use of JYNNEOS during outbreak, And subsequently, there'll be a publication of MMWR about the use of JYNNEOS vaccine during Mpox outbreaks. And subsequently, ACIP in October considered the need for longer-term vaccination strategy for the 2-dose JYNNEOS vaccine. So with that, I want to thank my ACIP co-member, Beth Bell, for her valuable input, as well as ex officio liaison members. As you can see, are policies, among them policies like the AAP, Jim Campbell, for Jafar Razek, who's the American Association for the Laboratorians, who's been a huge help, as well as other invited consultants, namely and especially Stuart Isaacs, who's been a huge help as well. Next slide. And then we've also, in the work group, there's been STIs, HIV, and Mpox experts, Kim Workowski in particular, Bonnie Maldonado has also, all of them have been fantastic, as well as immunization and vaccine safety individuals, and as you can see, other experts as well. And then finally, the CDC contributors, Brett Peterson, among others, but I really want to give a huge shout out to Agam Rao, who's been a spectacular work group lead, and who will be doing the presentations today, as well as Faisal, who's been just been fantastic. Thank you.
Thank you, Dr. Sanchez. Next, we will have Dr. Minhaj presenting on updates from the 2022-23 monkeypox outbreak.
Thank you. Next slide. So this is the epi curve displaying the number of cases reported to CDC from the beginning of the outbreak in 2022 until mid-June 2023. The peak of Mpox cases occurred during August of 2022, with persistent cases in low numbers since then. Next slide. Looking closer at the case counts from the beginning of the year to now, we see that cases have leveled off in February, with a 7-day moving average between 1 to 5 cases in recent months. On April 17th, Chicago started to notice an increase in cases after weeks of 0 detected cases. We will discuss this in later slides. Next slide. This graph displays the number of cases reported to CDC on the y-axis and the age distribution on the x-axis, with gender is in different colored bars. The gender and age distributions of Mpox cases has not changed since our February ACIP presentation. Most cases are among adult cisgender males. There are a small number of cases among women, transgender persons, and persons who identify as having another sex or gender. Next slide. The race and ethnicity of reported cases remains unchanged from what was reported in February. This graph shows the race and ethnicity distributed by month, with the total number of cases in each month listed above the corresponding column. Early in the outbreak, greater than 40% of cases were detected in white persons, but during the peak last year, Black and Hispanic persons were most affected. We see that a recent increase in the proportion of cases among white persons. However, small case counts make interpretation of this data difficult. Next slide. From April to May 2023, new cases of Mpox were detected in Chicago after months of very few cases. Many of these were among vaccinated people. This prompted the Chicago Department of Public Health and CDC to investigate this increase in cases. Next slide. From March 18th to June 12th, Chicago identified 40 laboratory-confirmed cases of Mpox. All were males with a median age of 36. 55% were vaccinated with 2 doses of JYNNEOS or 1 dose of ACAM 2000, and 13% were partially vaccinated or 1 dose of JYNNEOS vaccination. 33% were unvaccinated. 11 of these individuals were living with HIV, 10 of whom who were vaccinated with either 2 doses of JYNNEOS vaccine or 1 dose of ACAM 2000 and had well-controlled HIV. The median time from second dose of JYNNEOS to Mpox diagnosis was 8.4 months. This was a notable increase in cases in previously vaccinated people getting Mpox. So we looked at the clinical features, individual behaviors, and viral sequences involved in this cluster. Next slide. Individuals with 2 doses of JYNNEOS or 1 dose of ACAM2000 had self-limiting illness. There was a lower prevalence of mucosal lesions and none were hospitalized. Individuals with 2 doses of JYNNEOS or 1 dose of ACAM2000 also had a higher number of sexual partners 3 weeks before symptom onset compared to partially or unvaccinated persons. Preliminary sequencing indicates that the virus is the same B.1 variant of clade 2b, which is the predominant variant of the 2022-2023 outbreak. Importantly, there were no mutations that would confer increased pathogenicity. This investigation is ongoing, however, no similar clusters have been seen elsewhere in the U.S. With that overall epidemiology summary, I will be moving on to the epidemiology of Mpox in less affected populations. Starting with pregnant persons. From May 11th to May 31st, 2023, 27 cases of Mpox were reported to CDC occurred in pregnant people. All exposures were through close contact with a person with confirmed infection, including sexual and household contact. Infections occurred in all trimesters of pregnancy, and 11 or 40% received tecovirimat without adverse events reported. In terms of pregnancy outcomes, 11% had pregnancy losses at less than 20 weeks, 6 or 22% had live births, and 18 or 66% of pregnancies were ongoing. Next slide. Looking closer at neonatal transmission and breastfeeding considerations, of those 6 live births, 2 neonates developed lesions 1 week after their mothers became symptomatic. Both received oral tecovirimat and 1 received vaccinia immune globulin intravenous. Both neonates responded to treatment and were discharged home. 1 breastfeeding neonate developed face and chest lesions 6 days after the mother developed breast lesions. Importantly and separately, 1 woman with isolated ocular lesions continued to breastfeed her 2-year-old infant without transmission. Breast milk of this individual was tested on 2 separate occasions and was negative for monkeypox virus via PCR. Next slide. Here we describe details of 1 case of Mpox in a U.S. neonate. 12 hours after vaginal delivery, it was learned that the dad had active Mpox and had contact with mom prior to delivery. The mom developed lesions 1 day after delivery on the abdomen and tested positive for Mpox. The baby was given vaccinia immune globulin intravenous as post-exposure prophylaxis. On day 4, at 4 days old, the baby developed scalp lesions and tested negative for HSV and positive for Mpox. On the right side of the screen, you can see the scalp lesions evolve from day when the baby was 4 days old up until 13 days old. The baby was given tecovirimat and discharged at 17 days old. The lesions and the symptoms fully resolved 4 weeks after discharge. Next slide. I will also be discussing a case in a neonate in the United Kingdom. 9 days before birth, the dad had developed a febrile illness, followed by a rash that resolved prior to the baby's birth. 4 days after birth, a similar rash appeared on mom. And 9 days after birth, the infant also developed a similar rash and was diagnosed with both Mpox and respiratory adenovirus. They were treated with 14 days of enteral tecovirimat and intravenous cidofovir. This neonate was critically ill, requiring 4 weeks in the ICU and 14 days on mechanical ventilation before discharge home. This case here does highlight severity of illness in a neonate with Mpox and adenovirus co-infection. Next slide. Last meeting, we presented this data on characteristics of pediatric cases in the U.S. These cases make up less than 1% of detected cases. The exposure types are predominantly male-to-male sexual contact in adolescents, similar to what we see in adults, and often household contact in younger children. This data has continued to be monitored at CDC with 125 total cases, and the trends are similar to what are seen here. Next slide. Recently published was a report detailing exposures among children 12 years and younger from September to December 2022. The number of cases among these children are small, but it does highlight that Black non-Hispanic children continue to be the most affected. When each of these cases was examined further, the type of exposure in children was caregiver or household contact. The types of contact varied among the cases, but are often common activities within the home. Next slide. Another population of interest were healthcare personnel. Within the case report forms that states use and send to CDC, there was a question asking whether healthcare personnel were exposed at work. However, the number of responses suggested a large case number, something that would have been noted by states if this was accurate. When investigated, it was found that healthcare personnel often had exposures outside the workplace. After removing cases where other more likely exposures were possible, there were a minority of potential cases remaining, only 23, highlighting that healthcare personnel infections are very rare. We believe that this number, or 0.08%, is still an overestimate of the true number after discussing with state health departments directly and what CDC has heard on its consult service. Next slide. CDC has directly heard through its consult service from only 6 cases of healthcare personnel with Mpox with workplace exposure. Half were Sharps injuries while trying to aspirate or unroof lesions. CDC has since revised its recommendations to discourage unroofing lesions as vigorous swabbing is sufficient. Globally, most healthcare personnel infections are secondary to Sharps injuries. The other 3 cases highlight potential healthcare exposures, where in 2 cases, improper personal protective equipment was worn, and in 1 case where the exposure route was unclear. Overall, based on the limited number of healthcare personnel infections and the exposures highlighted here, the likelihood of healthcare personnel being infected at work appears low. Next slide. Now we will move on to discuss vaccine updates. Vaccine uptake has slowed dramatically following the peak of the outbreak in July and through September of 2022. This graph highlights that first and second dose administration since the beginning of the outbreak last May. Overall, first and second dose vaccine coverage are 36.7% and 22.7% respectively of the estimated at-risk population who are eligible for vaccination. Both first and second dose estimates are low, and 38 out of 54 jurisdictions are still below these national average coverage estimates, emphasizing the work needed to get at-risk people primary vaccination. Next slide. A key factor why increasing vaccination coverage is important is displayed in this mathematical model. This graph has the risk for Mpox recurrence on the y-axis and populations with partial or 2-dose vaccination on the x-axis. It suggests that the risk for future outbreaks depends linearly on the level of immunity in the population at risk, meaning the greater proportion that is vaccinated, the greater reduction in risk for recurrence. Next slide. However, when we look at the cumulative incidence of monkeypox virus infections relative to immunity, we see a different trend. Next slide. The graph shows that getting above 50% coverage with 1-dose vaccination is predicted to significantly decrease the risk of large outbreaks. Currently, only 7 jurisdictions are above 50% of at least 1-dose JYNNEOS coverage. Next slide. Looking at vaccine safety, the CDC vaccine safety monitoring is ongoing and uses 2 surveillance systems: the Vaccine Adverse Event Reporting System, or VAERS, and the Vaccine Safety Data Link, or VSD. VSafe data collection for Mpox vaccines was available from November 2022 through March 21st, 2023. Next slide. The adverse events most commonly reported to VAERS have been injection site symptoms, including redness, swelling, pain, and itching. Uncommon but expected adverse events that have been reported to VAERS include syncope at a rate of 49 reports per million doses and anaphylaxis at 2 reports per million doses. Myocarditis and pericarditis are adverse events of special interest. Observed rates are consistent with expected background rates. Next slide. VAERS and VSD data do not suggest an increased risk for myocarditis or pericarditis following JYNNEOS, but the possibility of a small risk cannot be excluded. The frequencies of local and systemic reactions reported to VSafe after Mpox vaccine were similar to those reported in clinical trials. No new or unexpected safety concerns have been identified. Next slide. Now we will move into vaccine effectiveness, or VE. This is updated data from what was previously presented at the February ACIP meeting. EPIC's electronic health record includes records from greater than 173 million patients across the United States. We performed a case control analysis matching 1 to 4 on the week of index event, HHS region, and gender identity. Cases were patients with an Mpox diagnosis or a positive lab result, while controls were selected from patients with an incident HIV diagnosis or HIV PrEP prescription. VE was estimated using conditional logistic regression and adjusted for age, race and ethnicity, social vulnerability index, and immunocompromising conditions. VE was stratified by route of administration and immunocompromised status. Next slide. Overall VE from partial or one-dose vaccination was 36%, with a confidence interval of 22 to 47, with a similar but slightly higher results for those with no immunocompromising conditions. Overall VE from two-dose vaccination was 66%, with a confidence interval of 47 to 78, again with similar but slightly higher for those with no immunocompromising conditions. The analysis was not sufficiently powered to examine the route of administration or immunocompromised status. Next slide. The next study with updated VE estimates is a case control study performed in 12 U.S. jurisdictions. Cases were identified from a jurisdiction's list of Mpox cases, while controls were identified from healthcare settings providing HIV PrEP or STI clinics. VE was adjusted here for age, race and ethnicity, and immunocompromised status. It was stratified by route of administration and immunocompromised status. Next slide. Overall VE for partial or one-dose vaccination was higher here at 75% with a confidence interval of 61 to 89, with similar results for those with either administration route. Overall VE for two-dose vaccination was 86% with a confidence interval of 74 to 93, again with a similar result for either administration route. Next slide. Looking specifically at immunocompromised persons, the point estimates were similar, but slightly lower than that of the overall estimates. However, the numbers are small within this subset and have wide confidence intervals that cross zero, making interpretations of these estimates difficult. Next slide. The last study is a case control study from New York State. Adult male Mpox cases during July 24th to October 31st served as cases, and controls were generated from adult male STI cases during the same time period. VE was adjusted for week of diagnosis, race, age, and region within the state. Next slide. VE estimates for one and two-dose vaccination here were 68 and 89% respectively. Next slide. VE of JYNNEOS against Mpox ranges from 36 to 75% for one-dose vaccination and 66 to 89% for two-dose vaccination between the three studies. Next slide. JYNNEOS vaccine is effective at reducing the risk for Mpox disease. Protection is provided by both one and two doses of JYNNEOS vaccine. The highest protection is provided by 2 doses, regardless of the route of administration. Further research is needed to evaluate whether immunocompromised status modulates VE, and further research is needed to understand the duration of protection. Next slide. I would like to acknowledge all the people that assisted with creating these slides and putting this together. Thank you.
Thank you. This presentation is now open for questions. Dr. Brooks?
That Epic Cosmos study, that was it had 173 million, and I was just curious about that. I mean, that's half the United States. And if there's can that be used for other studies if we have access like that? I was just very curious about that.
Yeah, I think Ian may be on the line that can better address that question.
Ian Krachalik, are you on the line? Can you answer that question? Maybe we can come back to that, Dr. Brooks.
It was slide 39 and 40 per the book here.
Dr. Carter, Rosalind, do you have any thoughts about that?
Is that the epic?
Yeah, right, that epic cosmos.
Hi, good morning. This is Rosalind Carter. I will just comment that that database, again, the 173 million refers to the number of potential patients across the U.S. that are part of EPIC electronic health records. That database has been used extensively for looking at COVID-19 cases as well as vaccination and vaccine effectiveness. So it's based on those relationships that we were able to extend that to look at vaccine effectiveness for the JYNNEOS vaccine.
And I guess theoretically the follow-up is that if that were so highly powered and we're looking at the numbers here, would that be the VE that we would believe is the most accurate, but also is the lowest? And that's speculation. That's a rhetorical statement. Thank you.
Dr. Brooks, just to clarify, are you asking about potential biases of this particular approach and how that might impact vaccine efficacy?
Almost the other way around. Is this the one that I would believe the most because it has the largest patient population? But you're right that since it's EPIC and it's not heavily used, I think, in FQHCs and other sites, that's actually a relevant point. Could be biased.
Thank you. Are there any additional questions, Dr. Sanchez?
No, I just wanted to comment that I think that we all know the imperfections of electronic health records, and I think that subsequently the two U.S. jurisdictions, the cases were really identified locally by that specific jurisdiction. So I think we have to take into account the imperfections of data retrieval from electronic health records versus those that are identified by local jurisdictions. So I would put more weight on some of the other studies.
And I think relevant to that, so first of all, thank you very much. That was a really excellent presentation, and this is more data than we've ever seen on monkeypox, so thank you for doing that. But just thinking through some of the opportunities of, in terms of the methodology, are you able to track patients longer term, number one? And then I think the second question I have is, did it require chart review to ascertain vaccination status, or were you able to ascertain vaccination status in the record? Is that even available?
Yeah, I think our lead for our vaccine effectiveness work might not be connected. Dr. Krachalik, are you on the line? Do you think maybe we could come back to that, Dr. Lee?
Sure, thank you. No, this just to say that we're aware of Epic Cosmos, but this is the first time we're starting to see it more regularly used in our meetings, so it would be helpful to understand a little bit better some of the strengths and limitations of the approach and the data source, generally speaking. But I assume we'll learn more over time, similar to VSD and other safety surveillance systems. Thank you. Any additional questions? Dr. Paling.
Yes, I wanted to say thank you to Dr. Minhaj and your entire team, because this is really incredible and so important, and it demonstrates how the vaccine campaign has significantly reduced the Mpox vaccine, and this is so important for health equity across the nation. And so I just want to say thank you for pulling so much valuable information to guide future discussions.
Thank you.
Dr. Juthani?
Thank you. I just had a question about the recent Chicago outbreak. So was the interpretation that the risk factors in those that had milder infections who had been vaccinated, received both doses, the cause, or was it thought, is it too small right now to be able to tell? in terms of whether it was risk factors that maybe led to those breakthrough infections more so or not? And are there going to be additional follow-up in terms of continued case ascertainment as we go forward and potentially see additional cases like that? Thank you.
This is Agam Rao. I can start with a response to that. So for that cluster, there was a MMWR publication that came out just yesterday that actually explains what we know so far. So there are 40 cases reported in that report, and there was a mix of both subcutaneous, both doses subcutaneous and intradermal. For the most part, there was only one person who received both an intradermal vaccine dose. So I know there was a lot of concerns about whether intradermal vaccines were the problem, and that does not appear to be the case. Also, from the data that Dr. Minhaj has presented, we know that the effectiveness, real-world effectiveness of subcutaneous and intradermal have been comparable. There's the work has been really extensive, led by the Chicago Department of Public Health, and there has been no smoking gun that's been identified to really explain why those breakthrough cases have occurred, predominantly affecting people who have received both doses of the vaccine. But we have some hypotheses, and among those are perhaps there's a lot of exposures occurring within a network that is vaccinated. And so we can see infections, and when there are infections that occur, it can spread within that network. There are other hypotheses that we're evaluating. There's also there's continued surveillance occurring from Chicago, and the investigation is not completed. Basically, we're still continuing. Chicago is continuing to investigate to see what can be determined. I'll ask Dr. Braden if he has anything additional to add from CDC, the subject matter, our incident commander for the Mpox response.
Well, I'll just say that, we did look at the virus also to make sure that there were no changes that were associated maybe with increased pathogenicity or immune escape, and that does not seem to be the case. And then, of course, the most worrisome hypothesis as to why we're seeing these cases would be that the immunity has waned over time. And so we're looking at that with these studies and others to determine what the reactivity is in titer levels and so forth over time, and we'll get into that more in the next presentation, and to determine if there's something more that we need to do with our vaccine strategy.
Just to follow up to that question, and if this is going to be answered in the next presentation, that's fine. For the studies that were presented for 1 dose and 2 dose, do you have the average time since vaccination in the groups? Or time since last dose?
I can say that we've had breakthrough infections. So we've had infections after vaccination occur as early as in August, which is very soon after the vaccine doses were administered, and it has continued up until now for people who were vaccinated very early on. Dr. Minhaj, do you have anything to add to that?
No, the only thing I was going to add is for the Chicago cluster, the median time was 8 months, but we have seen breakthroughs before then too, so thank you.
Thank you. Any additional questions? Okay, we will move on to the next presentation. Thank you very much. Next, it'll be Dr. Agam Rao, who will be presenting on use of JYNNEOS during monkeypox outbreaks, clinical guidance.
Thank you. So I'm going to focus only on outbreaks in general, so not specific to the outbreak that is currently going on right now. But as Dr. Braden has mentioned, the presentation after this one will focus back again on this particular outbreak. Next slide. So during the February meeting, as Dr. Sanchez has already mentioned, ACIP voted to recommend the 2-dose JYNNEOS vaccine series for persons aged 18 years and older at risk of Mpox during an Mpox outbreak. Next slide. Vaccination with JYNNEOS is a 2-dose series. During an Mpox outbreak, JYNNEOS may be administered as post-exposure or pre-exposure. A concerning exposure should trigger consideration for post-exposure vaccination, regardless of where the exposure occurred. So, for example, whether skin-to-skin contact with an infected lesion occurred in a healthcare setting or in the community, the guidance is the same. The 2-dose PEP series should be administered. For pre-exposure, whether specific populations, for example, children or pregnant persons, should receive vaccination is dependent on the risk during that specific outbreak. So since we cannot predict what the future circumstances might be for an outbreak, whether it's associated with a traveler, a lone traveler from an endemic region, or imported pets, as occurred in 2003, or male-to-male sexual contact, or some other mode, the goal of our clinical guidance is to provide general information that can inform decision-making for specific Mpox outbreaks that might occur in the future. Next slide. So this presentation is focused on that clinical guidance, and it will be included in the published MMWR describing the ACIP recommendations about the use of JYNNEOS during Mpox outbreaks. The presentation is organized into three main categories that are shown here: vaccinating at-risk populations during an outbreak, vaccinating healthcare personnel or HCP and certain laboratorians during an outbreak, and administration guidance. And there are several topics within each of these main categories. Next slide. So the first topic is vaccinating at-risk populations, and we'll begin with pediatric patients. Next slide. We know from the published literature that persons less than 18 years of age have developed Mpox in endemic countries. The work group reviewed data about cases that occurred during 1970 to 2022. In Central and West Africa, pediatric MPXV clade 1 and clade 2A have been described. In the earlier years within this time period, there's been increased incidence and illness severity reported among children less than or equal to 8 years of age, likely because these younger children had not been routinely vaccinated against smallpox, and the adults within that time period had. But in more recent years, you can see that, the work group saw that there's no difference in incidence or severity in children compared to adults, likely reflecting cessation of childhood smallpox vaccinations among persons who were adults at the time of the evaluations. In the United States and United Kingdom, pediatric infections have been limited to clades 2A and 2B. In the 2003 outbreak associated with the infected pet prairie dogs, 2 children were hospitalized, but eventually fully recovered. And in 2021, when a traveler from an endemic country traveled to the United Kingdom and was diagnosed with Mpox, a household member who was a child was diagnosed with Mpox and was also hospitalized but recovered. There's been no severe manifestations among children that during the current U.S. outbreak. And in the UK, the only severe manifestation that we're aware of in a child was in the neonate in the United Kingdom that Dr. Minhaj already presented about. That patient had a co-infection with adenovirus. And so we don't know what contribution that the adenovirus had to the severity of that patient's illness. And that child eventually did recover as well. Next slide. So JYNNEOS is FDA licensed for persons greater than or equal to 18 years of age. But during the outbreak, it has been administered for children. However, it's been administered to fewer children than adults just by nature of this particular outbreak. So you can see from the image on the right side that pediatric patients 12 to 17 years of age have received it much more often, their first dose, than the younger age children. There is, however, when we look at just the pediatric patients from 12 to 17 years of age, there's no safety signal identified via CDC vaccine safety surveillance systems. There's no efficacy data from pre-licensure trials because FDA was licensed the vaccine for only those 18 years of older. And we were unable to evaluate real-world VE during the current outbreak. So the work group was uncomfortable making an ACIP proposal for a vote, particularly also because there's an NIH clinical trial underway to evaluate the safety and efficacy of the vaccine in persons 12 to 17 years of age. Now, for people younger than that, for those aged 0 to 11 years of age, there's been very little first dose vaccines administered, and really second doses were very rarely administered to any of these pediatric patients for whom there was not male-to-male sexual contact, for whom it was given as post-exposure prophylaxis. There were no safety signals identified via CDC surveillance systems for this group either. Even though there were few vaccines administered, there was no efficacy data from pre-licensure trials for the same reason there was no efficacy data for the 12 to 17-year-olds. We were unable to evaluate real-world VE during the current outbreak, and perhaps more concerning, there's additional issues for those who are 0 to 11 years of age. There's concerns that the dose may be different for those in the younger age groups compared to those in the older age groups, and this has not been studied. There's also not, to our knowledge, clinical trials or other studies that are planned at this time. There is data from a recent publication that was actually just very recently published in the Lancet Infectious Diseases that seems to indicate that in the United Kingdom, a single dose that was administered to pediatric patients, median age 5 years, has been safe and also effective. Next slide. So the ACIP work group drafted this guidance that's shown on this slide for the MMWR. For persons 6 months to 17 years, JYNNEOS should be administered as PrEP or PEP as indicated by public health authorities for a specific outbreak if a high-risk exposure occurs. For younger children, example those less than 6 years of age, clinicians should be aware that no studies involving JYNNEOS have been performed to determine the appropriate dose. Decisions about vaccination with JYNNEOS should involve risk-benefit assessment for every pediatric age group during a specific outbreak. And after completion of the ongoing NIH clinical trial, ACIP may consider a vote regarding use of JYNNEOS in children 12 to 17 years of age for outbreak situations. For those less than 6 months of age, the work group felt that vaccinia immunoglobulin intravenous or VIGIV should be administered in lieu of JYNNEOS if PEP is indicated. Next slide. This table has been shown during previous ACIP meetings. While MPXV DNA has been detected by PCR in a number of samples, replication-competent virus has been detected or isolated from only a subset. And in the last column in this table, you can see that even among those for whom replication-competent virus has been detected, epidemiologic data to date has not always proven that those specimens are infectious. So we only have data to indicate that skin, oropharynx, and anal rectum, lesions from skin, oropharynx, and anal rectum are sources of MPXV infection. I want to focus, though, for the next few slides on the guidance that the work group developed for persons who are pregnant or breastfeeding. So you can see here in the red box, there's insufficient data for vaginal and breast milk samples, whether MPXV can be transmitted after exposure to these. Next slide. But historically, we do know that Mpox has been transmitted pre- and perinatally. Neonatal outcomes among neonates born to mothers who had Mpox included a stillbirth, self-limited rash, and healthy outcomes, healthy neonates. During the 2022-2023 U.S. outbreak, outcomes among pregnant women are being evaluated, as Dr. Minhaj mentioned. Transmission to a neonate is known to have occurred, as presented by Dr. Minhaj as well. So we do know that there is risk in pregnant persons. Next slide. We don't know, however, about the use of JYNNEOS in pregnant persons. It's unknown if JYNNEOS was administered to pregnant persons during this outbreak. We don't actually have a variable that captures whether the individual was pregnant. If there was, though, we can say that there were no adverse events passively reported to VAERS. We have not received any such reports. The 2022 ACIP recommendations, which are for persons at occupational risk for exposure to orthopox virus infections, actually explicitly says that persons at risk for occupational exposure who are pregnant, that JYNNEOS is not contraindicated in pregnant persons. And that was something that our ACOG representative felt strongly about and we discussed at length. Next slide. Now, regarding breastfeeding, Mpox spread during breastfeeding. What we know is that Mpox is known to have been transmitted when a child was exposed to Mpox skin lesions under the breast, as Dr. Minhaj mentioned. But as he also mentioned, it's not known to be transmitted via breast milk. And for the one patient for whom this was tested, breast milk samples were negative for MPXV DNA by PCR. There's also, similar to pregnant women, there's no data that we have about whether breastfeeding persons received JYNNEOS. We believe they did, but we do not have this data for sure. There are no VAERS reports about people who specifically were breastfeeding. So next slide. This is a bit of a busy slide, but it is text that is nearly identical to what is already in the 2022 ACIP recommendations about pregnant persons who might receive the JYNNEOS vaccine for pre-exposure in occupational settings. And the work group felt the same language could be used for this MMWR. So JYNNEOS is not contraindicated in persons who are pregnant or breastfeeding. Available human data is insufficient to determine vaccine-associated risks in pregnancy. However, animal models, including rats and rabbits, have shown no evidence of harm to developing fetus. The safety and efficacy of JYNNEOS has not been evaluated in breastfeeding women. It is not definitively known. We just have that one person. It is not definitively known whether JYNNEOS is excreted in human milk. Data are not available to assess the impact of JYNNEOS on milk production or the safety of JYNNEOS in breastfed infants. However, because JYNNEOS vaccine is replication deficient, it likely does not represent a risk of transmission to breastfed infants and can be administered to women who are breastfeeding after weighing the benefits and the harms. If high-risk exposures cannot be avoided or have already occurred, persons who are pregnant or breastfeeding may receive JYNNEOS. Next slide. I'll now move on to vaccinating healthcare personnel, or HCP, and certain laboratorians during an Mpox outbreak. Next slide. So as Dr. Minhaj has mentioned some of this, but during the 2022-2023 U.S. Mpox outbreak, to date, we have not received any reports of laboratory personnel who were exposed in the workplace and developed Mpox. Among HCP, we're aware of 23 potential exposures, but we believe that it may be less than that. Most of those, as he mentioned, were associated with sharp injuries while attempting to unroof, open, or aspirate Mpox lesions, and some were associated with suboptimal PPE use. Historical data from endemic countries, there's also no data about laboratory personnel who have acquired it in the line of work. And for HCP, the cases that were reported in the published literature seem to be those that are associated with providing care to family members or friends in homes, or with little PPE available. The next slide. So the work group considered this table again that describes the detection and transmission of MPXV during the current outbreak, the MPXV in human samples and implications for transmission. And you can see in the red box that there are a lot of specimens that could potentially be sources of infection transmission. So again, we don't know for sure whether or not many of these could lead to transmission, but we do know that that replication-competent virus has been detected in many of these, as shown in the middle column. Next slide. So the 2022 ACIP recommendations for persons at occupational exposure did not have this data about that was shown on the previous slide. So this information that's shown on this slide is what was recommended. It says for research laboratory personnel and clinical laboratory personnel performing diagnostic testing for orthopox viruses, ACIP recommends use of JYNNEOS for primary vaccination as an alternative to ACAM 2000. And then for healthcare personnel who administer ACAM 2000 or care for patients infected with orthopox viruses, ACIP recommends use of JYNNEOS as an alternative to ACAM 2000 based on shared clinical decision-making. So the work group discussed this, and given the additional data that is now available to us, wanted to make modifications during Mpox outbreaks. And those you can see on the next slide. So the changes are shown in red. So instead of orthopox viruses, we've replaced that with the word Mpox because these outbreak recommendations are limited to Mpox. We've also specified pre-exposure vaccinations so that it's completely clear. And then as far as the additions to the populations, given that that table that I showed that indicated that replication-competent DNA was present in some specimens, we added clinical laboratory personnel who handle specimens that may have a higher possibility of containing replication-competent MPXV, example, lesion material, throat swabs, oral swabs, rectal swabs, to the group of people who, based on shared clinical decision-making, could receive JYNNEOS. We do, though, have in a footnote here that the vaccination is not routinely recommended for clinical laboratory personnel who perform routine chemistry, hematology, and urine analysis testing. And we've also explained this part about the vaccination of healthcare personnel. So the 2022 ACIP recommendations were drafted and were voted on before the the Mpox outbreak, this current Mpox outbreak. And at that time, the vaccination that was being referred to of healthcare personnel who were working with replication-competent viruses, that was drafted based on the fact that we know that there are U.S. physicians and other healthcare personnel who travel abroad, for example, to work with various agencies to provide care for patients with Mpox, and we wanted to ensure that they were covered. It was not intended, it was not knowing that there was going to be this large outbreak in the U.S. And so based on the data that we have about this outbreak, the limited spread to healthcare personnel, and what we know historically, we've added to the footnote here that healthcare personnel who care for patients with Mpox or administer ACAM 2000 can receive it based on shared clinical decision-making, but recommended infection prevention and control practices are effective in minimizing transmission. Vaccination can be offered based on site and activity-specific biosafety risk assessments, example, identification of laboratory procedures with a high likelihood of generating aerosols, or inadequate PPE availability. So essentially, the work group felt that it is not necessary for all healthcare providers working in STI clinics, for example, to be vaccinated. Next slide. So I'll move on to the third part of this presentation, which is administration guidance. Next slide. So co-administration of JYNNEOS with COVID-19 vaccines was discussed during the last ACIP meeting. So there's this guidance that's listed here on this slide is already on the CDC website for both the COVID-19 vaccines, interim clinical guidance, and also the JYNNEOS CDC interim clinical guidance. And what it says is that there's no required minimum interval between receiving any COVID-19 vaccine and JYNNEOS vaccine, example for Mpox prevention, regardless of which vaccine is administered first. But people, particularly adolescent and young adult males who are recommended to receive both vaccines, might consider waiting 4 weeks between the vaccines. And this is because of the observed risk for myocarditis and pericarditis after receipt of ACAM 2000 orthopox virus vaccine and COVID-19 vaccines, and the hypothetical risk for myocarditis and pericarditis, which has not been shown in our VAERS data at this time, but which we're not ready to say does not occur entirely. We want to wait for more data. Because of that hypothetical risk, that is why that guidance was drafted. However, if a patient's risk for Mpox or severe disease due to COVID-19 is increased, administration of JYNNEOS and COVID-19 vaccines should not be delayed, so that 1 month need not be followed in between the 2 doses. Next slide. I'll now move on to implications of JYNNEOS administration in close temporal proximity to immunoglobulin products. So the reason this came up is JYNNEOS is technically a live virus vaccine. It is a non-replicating virus vaccine, but it is a live virus vaccine. And so the work group discussed that antibodies to measles and varicella are high in immunoglobulin products, and that is why administration of these in close temporal proximity the MMR vaccine and immunoglobulin products can prevent the vaccine from entering cells and being effective. And there are explicit guidance about repeating the dose, things like that, just because the immunoglobulin products can affect the effectiveness of a vaccine. But antibodies to orthopox viruses are believed to be very low in most immunoglobulin products, for example, IVIG, and will likely remain low in the future. Since this is not a vaccine that's given to the entire U.S. population. Now, this is a theoretical hypothesis by us, but that is what we in the work group believe. Antibodies to orthopox viruses are present in VIGIV, which is purified immunoglobulin from persons vaccinated against smallpox, and is a different product from IVIG. So VIGIV is actual persons who are vaccinated against smallpox. It's pooled from immunoglobulin from all of those people. And whether these could prevent the vaccine from being effective is unknown. So next slide. So because of that, the work group drafted the guidance that most immunoglobulins, there's no precautions necessary if JYNNEOS is administered in close temporal proximity to IVIG. In the case of VIGIV, it could interfere with immune response to JYNNEOS. We just do not know. So ideally, administration of JYNNEOS should be delayed if VIG was recently administered. The duration for which it should be delayed is unfortunately unknown. We don't have any data to inform this, but we do think it's going to be very few people for whom this would occur. So during outbreaks, it's acceptable to administer a dose of JYNNEOS and then consult public health for case-specific guidance about an additional dose at a later time. The reason we think that it would be very rare for people to receive VIGIV and also the JYNNEOS vaccine is that VIGIV is being given for treatment of severe manifestations of Mpox. So if someone has Mpox, they're not recommended to get the JYNNEOS vaccine. They're expected to have antibody levels that are appropriate, and there's no vaccination recommended. And so those people are unlikely to get the vaccine. There is the chance that the very youngest of children would receive VIGIV because of an exposure when they were less than 6 months of age and then need one later. There's also the possibility that someone may have received VIGIV for a orthopox virus vaccine that is not Mpox, like vaccinia virus, for example, and would then need JYNNEOS later. And so those were expected to be so rare that they should be handled on a case-by-case basis with public health. Next slide. So this is our last slide about other administration guidance that would be in the ACIP MMWR. Unintentional delays do not require restarting the series. The second dose should be administered as soon as possible, even if more than 1 year has elapsed. And in settings where subcutaneous administration is not preferred, for example, vaccine is in short supply, the vaccine can be administered intradermally, and we've already shown data to indicate that it's just as effective. In settings where intradermal administration is not possible, for example, because staff are not trained or uncomfortable, the jurisdictions may administer subcutaneous vaccines and prioritize first doses of the 2-dose JYNNEOS series, but the second doses should definitely be administered as soon as the vaccine availability allows. And all of these decisions about vaccine administration should ensure equitable distribution of vaccine doses. Next slide. And then I want to thank all of the people who were involved in developing all this clinical guidance. It involved a lot of work looking at the historical data and discussing with various partners. I want to particularly thank Dr. Faisal Minhaj, who performed a lot of these reviews of the available data, Dr. Jim Campbell for AAP and AAP COID and Red Book, who also considered these, Dr. Jafar Razik, Mark Russi, who provide input from the occupational health perspective as well, and then everyone else listed on this slide. And I can take any questions now. Next slide.
Thank you. Bless you. This presentation is open for questions. Dr. Long.
I have a couple questions. I was surprised after you told us about the difference between ACAM and JYNNEOS, both in its contraindications and in especially secondary lesions, that there was not a preferential recommendation for JYNNEOS. Is there a reason for that?
Well, JYNNEOS, some laboratorians, for example, prefer to receive ACAM 2000. They've been receiving it for years. Their take is actually minimal, if anything, at this point. They're comfortable and familiar with it. And so we didn't want to remove it, imply that there was something wrong with ACAM 2000. I will say, though, that the ACAM 2000 doses, I don't think other than laboratorians, nobody really received ACAM 2000. Everybody, health departments were proposing only the JYNNEOS vaccine. And yeah, so our interim clinical guidance mentions both, but JYNNEOS was absolutely the vaccine that was used by non-laboratorians throughout this response. I know there was one person in the Chicago cluster who received ACAM 2000. That person did not get vaccinated in the United States.
Has there been any secondary transmission from secondary sites with the ACAM 2000?
It wasn't used really as part of this outbreak, but we do know that when it is given to people that that there can be spread. We're not aware of any vaccinia virus secondary infections that have occurred in the last 2 years since this outbreak has started. We do routinely get like a couple consultations each year from people who receive ACAM 2000 in the military, for example, who end up having close household contact with a family member or somebody else and have spread vaccinia virus to that person, but that has not occurred in the last 2 years. That has not occurred as part of this response.
If there's no one else, I have a second. The myopericarditis that occurs in young males, especially after coronavirus vaccine, is very different from the myocarditis that occurred following smallpox vaccines, and I assume that you are concerned about both in onset and offset and severity. So I understand that it would make sense to separate them, and I think that's a wise policy, although I don't think it would lead to much confusion about which vaccine was associated with the clinical outcome. But I do wonder if it's fair, the wording of your recommendation that people might consider delaying for 4 weeks between vaccines. People might consider. I think we generally make recommendations for providers, or we just say a period of 4 weeks might be considered. I think it sounds like this puts it on the adolescent to know and then say, I want to have 4 weeks. I just wondered why you chose that wording, and I would suggest you change it.
Yeah, that's slide 72, if you could pull that up now. Yeah, I can't recall at this time why that specific wording was used. I know that it was reviewed by both the COVID vaccine subject matter experts and the CDC subject matter experts, or sorry, the pox virus subject matter experts, and somewhere along the way that wording was used. I can check back with different folks and bring that issue to them.
Ms. Hayes?
Yes, Carol Hayes with the American College of Nurse Midwives. I had a question about the stillbirth. Do you have any data on what the estimated gestational age was when the stillbirth occurred? And was there viremia in the infected pregnant person? Do we have any data on what the cause of the stillbirth was?
No, I don't think we have that data at this time.
Thank you.
Dr. Freihofer?
Sandra Freihofer, American Medical Association. This was an excellent presentation. Really appreciate the update and appreciate all that CDC has done and helping us with this outbreak. The slides that were put on the website are significantly different than what was shown today. They've apparently been significantly updated. And is there any way that you could update the slides on the website so they can be downloaded so we can share with others?
Yeah, so yeah, you're right. I changed the order of a few slides from what was posted yesterday, and I believe we are attempting to update what's on the website, but that might take some time. I don't know if ACIP leadership wants to add anything. There's no difference in the subject matter in information. I think there's just the order of certain things that have been changed.
There's actually some deletions. I mean, some of the slides didn't have the numbers filled in. I mean, there's some significant differences, and it would be very helpful to have the updated slides. Thank you.
Thank you, Dr. Freihofer. We'll ensure that those get updated. Dr. Long?
If we have time for one more question, it's actually to Dr. Wharton and Dr. Romero. If you could help us think about this a little bit. I just have learned that the vaccine is not licensed under 18 years of age, the one we're talking about. So thinking about giving it as pre-exposure prophylaxis and to children 2, 3, 4, or 6 months of age, 5, 6, 7, 8, I can see maybe thinking about sexually active adolescents. But tell us how to think about that. I mean, especially with vaccinia immune globulin available for post-exposure prophylaxis. We have required lots of safety things for us to make recommendations. And I also just learned the nuance that this is not a vote for a recommendation, but it would be clinical consideration. I think of them as the same responsibility and the same level of heft behind them. So could you wax on a little bit about how we should think about this?
If I could just add one thing before Dr. Wharton speaks. So the work group actually agonized over this quite a lot, and we're thinking about whether the guidance for pre-exposure for pediatric patients should be different from post-exposure. In the end, what we decided was that we don't want to tie our hands if in a future outbreak it makes sense for that particular situation for certain children to receive the vaccine. And so we wanted to keep it general and say, well, if there's the same data that it is, the same data is available, whether it's for pre-exposure or post-exposure, it would be the clinical guidance specific to the outbreak at the time that would determine which age groups would get it as post-exposure or pre-exposure. We didn't want to specify that in this MMWR because we don't know what the future holds. We don't know if it's predominantly 4-year-olds that might be affected by a future outbreak involving some animal versus what we're seeing right now, which is male-to-male sexual contact.
Yeah, just to add to Dr. Brow's comments, I think as we're envisioning outbreaks that haven't occurred yet, clearly recommendations for vaccination of children would be made in the context of that outbreak with, I think, careful consideration and thought. And it would be done carefully and with due deliberation. My understanding in the current outbreak setting is these really were the recommendations that were made for vaccination of persons under 18 years of age were made with the consultation of public health, and those were really, for the most part, I believe, individual consultations for guidance, and so I would expect a high level of engagement and due deliberation for any future outbreak recommendations for vaccination of children.
Could you add that language, because you have it here for deciding, about delaying between and what the particular circumstance is. I would think that that's what we're talking about now is even more important, that you have some consultation and not just decide because this is there that you could willy-nilly give it to a 6-month-old without more consideration. And the other thing is, I think when there's ever angst in a work group, we should be told. Because I almost missed this, because I don't know enough about it to know what the license is. And this would be off-label recommendation without giving us those, clear-cut guidelines. We like to know about angst so we can share in it.
Well, I see Dr. Sanchez and Dr. Bell's hands are raised, so I think they want to share the angst. But I do want to, before you respond, Dr. Sanchez and Dr. Bell, I did want to, my worry is a little bit about sporadic cases. So in the context of an outbreak, I anticipate public health would be deeply involved. I worry a little bit that without at least a little bit more of a guidepost around pediatric patients, since this is essentially off-label use, that if for whatever reason people look to these guidelines and or guidance, clinical guidance, and for whatever reason public health is not deeply engaged in the case, which again I assume they would be because of the testing required, I think it would be helpful to just delineate the concepts around risks of ongoing exposure, to your point about whether or not this is a teen who might have ongoing sexual contact versus this is a one-time household exposure in a very limited, time-limited setting, to guide that question about IG use versus VIG versus vaccine. And it's a little unusual because it's essentially off-label use and with the same dose all the way down to the youngest age groups, and I get a little bit uncomfortable with that. So, and then of course the risk of severe disease. So I do think that there's maybe a little bit more of a framework that could be embedded into it and more clear guidance around ensuring that people call public health to provide that guidance. Even just that clarity, I think, would at least avoid any unnecessary exposure or angst about decision-making, because all of us tend to do different things. Dr. Sanchez and then Dr. Bell.
No, thank you. And we, as a work group, certainly struggled with what you're mentioning, Dr. Long. And actually, our first consideration was whether to have actually a vote about administration of this vaccine to those less than 18 years of age. And that's why, because of the lack of data, we felt that that was not appropriate, and we would just make a clinical consideration on case by case during an outbreak. We actually presented, Agam and myself, we spoke at the AAP ID Society, Pediatric ID Society meeting, and so this was all discussed and presented to them. And we also looked at the age range involved and felt that less than 6 months, we would prefer to give the vaccinia immunoglobulin rather than the vaccine. And really, we also are waiting, like was discussed, for the NIH trial in those who are 12 to 17. And yes, I mean, we're talking more proactively with respect to adolescents who are sexually active and have risk factors. But actually, I think it goes beyond public health. I think that probably we also need to state about pediatric infectious disease specialists, because in all honesty, I know locally the public health department will be calling us. And we have been giving, we gave the vaccine actually to an 11-month-old because of a household exposure. And then the other thing is that they're just yesterday or 2 days ago in the Lancet Infectious Disease in the UK outbreak, they vaccinated children with the same dose as the adult dose. They had a small number and
87.
87, and the median age was 5. And they actually looked at immunogenicity in small numbers, and they did respond appropriately, and they reported that it was safe as well. They had just minor side effects. So I think it's reassuring, but I think there's still a lot that we still need to know.
Dr. Bell?
Yeah, thank you. I wanted to actually thank the committee for this input. You know, I would just mention again that what we were asked to do was to provide some guidance with respect to future outbreaks, some sort of flexible kind of general rules of thumb that presumably would just help to sort of provide something for a situation in the future, the details of which we don't know right now. And presumably there would be much more specific guidance in the context of an actual outbreak. So that's why what you have here are clinical considerations. And it was difficult, I think, for us in the work group to be more specific, not knowing what the particular circumstances would be in this future outbreak that we're providing some guidance about. And so it was very challenging and difficult, as Dr. Sanchez says. I do think that the suggestion that Dr. Long and Dr. Lee are making about providing some further guidance about how to think about, especially individual cases, small numbers of cases in young children is a good idea. And I hope that we can, Dr. Rao can work on that a little bit with the work group so that we don't end up in a situation with somebody doing something that we think should have required some additional consultation.
Dr. Bell, I feel you may have answered many questions because I just had 3 hands raised and they all went down. Is there anything anyone would like to add? Dr. Romero.
Yeah, I just want to make a comment to Dr. Sanchez's statement. You know, I can tell you that as director of a former health department, I think that in unusual cases like this, the health department would not consult just an ID, right, a PDID. They would seek consultation with the experts, which is the CDC. I have done so in the past when I've had unusual cases and encourage my colleagues to do the same. So I think our public health jurisdictional experts would reach back into the CDC to our national experts. So I just want to put everybody's anxiety to rest on that issue.
Very quick comment. I really like Dr. Bell's word guidance, and it is something that I've used editorially to distinguish guidance from guidelines. And in our work groups that I participate in, clinical considerations are guidelines, almost always. And if they're this kind of level of difference, I think you might consider using the word guidance, because guidelines infers a basis in evidence, the congregation of experts to look at the evidence, the weighing of the risks and the benefits, and a final decision. And then you've got guidelines. So we haven't used the word, at least in the journals that I've been involved with, of guidelines in the last 25 years, unless that kind of thing exists. They were used very promiscuously earlier, but now they're not. Not in the journals I edit.
I think we're okay because typically CDC issues clinical guidance in this instance. But are there any other questions? Dr. Lair.
Yes, thank you. Could you go to slide 55? I'm just wondering, for the people who are asking for guidance and to help the work group, is what's in slide 55 what you're looking for? It says, for persons 6 months to 17 years, et cetera, as indicated by public health authorities for a specific outbreak. That's...
Yeah, I think the slide numbers have changed a bit since.
It's about 4 slides after the beginning of your talk.
So I think it's slide 60. Is this the slide?
Yes. So how would you want this phrase to help Dr. Long and Dr. Lee to sort of give guidance to the work group? How would you want this phrase? Thank you.
Well, so as indicated by public health authorities for a specific outbreak, I think to Dr. Romero's point, most folks would have public health involved. Honestly, there are some times where it just says, call CDC for this drug or this vaccine. I think something as simple as that is call the monkeypox hotline or whatever it is to be able to just direct people to ensure, please consult your public health, local public health, CDC is available to provide guidance as needed. I think that could be helpful just in terms of consistency of approach. Dr. Long?
I would like this to say should be considered rather than should be administered. I think, everybody's high risk is not the same.
Yeah, we can certainly take that back to the work group. I think the work group members felt that it should be administered because they were saying that we should, absolutely, if we have a child in our clinic who is 5 years old and who had a concerning exposure, it should be administered. And they didn't want it to sound like it was a lower sort of lower firmness in terms of what should be done. And then what I don't have on this slide, because it's not specific to the JYNNEOS vaccine, but MVA vectors have been used in other vaccines in Africa and in Germany in hundreds of patients without any safety signals. And so that further, I guess, made the work group feel that if there is an exposure, they would want the patient to receive the vaccine and for people to not hesitate when deciding.
And I know you had to decide on some age group. For other live virus vaccines, there's really a difference at about 12 months of age, and for many kill vaccines too, about how babies respond. So some of that may be related to passive immunity still being present for something like measles or varicella, but some of it looks like it really is, especially for varicella, you just don't respond the same way under 12 months of age as you do over 12 months of age. So I appreciate you had to put some kind of a age here. I really think it's very unlikely that a 6-year-old and a 12-year-old responds differently than an 8-year-old. They're more immunologically capable than an 18-year-old, but I'm a little worried about that younger end. But I don't know that it should be changed. I don't have any real data. It's just extrapolation from other live viruses and live virus vaccines.
Yeah, we agree. We did discuss it with COID and Red Book as well, and it sounded like they were all supportive of 6 months. So that's why that was chosen.
And certainly would be unusual for the mother to have significant antibodies during pregnancy to interfere with the uptake of that vaccine in older than 6 months of age.
Dr. Daly.
Yeah, I think we're settling in a good place. I think for me, because JYNNEOS is available for adults, I think we need more explicit. So there's two pieces to me at least, which is that the risk assessment is done very carefully. Is this a high enough risk situation? And then just that we're explicit about the process. And then with that, I would feel comfortable. And it seems like a little bit more wording about that here would be helpful. But I think we're landing in a good place.
Dr. Lehr?
So I think we're landing in a good place, but I'm hearing some hesitation from the work group. And so I'm wondering if this guidance should say something should be administered with consultation as opposed to as indicated. But that's being a little bit more prescriptive, and there are probably very talented physicians who know this stuff cold and don't really need to consult. I would automatically consult. So I just want to know if people want the wording to be a little more prescriptive with guidance by public health authorities.
I'll just add that we can certainly change that wording to with guidance, but what we intended by that was that whenever there's an outbreak, there's going to be interim information on the CDC website specific to that particular outbreak. So whatever the recommendations for that specific outbreak are for the age groups, it'll be much more granular in that document, and that's what should be referenced. That was the intention, but if that's not being communicated well, then we could modify it to make sure that it is.
Yeah, so, no, I agree with you. And the only hesitancy during the work group was really the lack of data. And we obviously are waiting for the 12 to 17-year-olds data from the NIH. And there are no planned studies in 11 and less than that. But I think that that we have a vaccine that so far has been found to be safe. And I agree. I mean, I think that rewording some of this information, in consultation with, the public health authority has to declare the outbreak, first of all, and at least locally, and then with consultation, I think that's reasonable.
Dr. Bell?
I was just going to mention, go back to this point about the difference between guidelines and guidance or recommendations. And this is meant to be overall general guidance with the expectation that there would be more specific recommendations in the context of a specific situation. Having said that, I personally am not wedded to the wording here. And I think if the committee in general would feel more comfortable with, for example, should be considered as opposed to should be administered. I personally, don't have a problem with that sort of thing. So while I think that the work group's rationale for choosing to sort of frame this with this level of specificity as guidance took a lot of thinking and was, I think, very well considered. I also appreciate the feedback from the committee, and I think that, as I say, I personally am not wedded to any particular wording, and I think we could come up with something that perhaps is less open to misinterpretation than perhaps what we have here.
Dr. Brooks? Oh, actually, Dr. Wharton wanted to respond just briefly.
Well, just in looking at this wording, it does feel like this is
with the assumption that there has been a high-risk exposure or it's a high-risk situation. So maybe the bullet before is the assessment of whether or not the exposure or environment is really a high-risk one. And in the event that it is a high-risk one based on that assessment, then vaccination should be given.
Agree, that context would be really helpful. And it's probably somewhere embedded in what all the documents you've written already. It's just that it's not showing up on the slide, but I think the point is just to highlight it as a component of that decision-making. And since I have the floor for another 5 seconds, I just worry that this reads as a recommendation should be administered. Again, I realize it'll be under clinical guidance, but I think the point is just make sure you do that risk assessment, make sure you're engaged with your colleagues who are experts in the area, and make sure you're aware and reaching out. I think the downside, just to be clear, is if there's a delay in administration or you lose that patient and you had that one contact, that's the trade-off. So I think you'll have to consider that in terms of your decision-making about how to frame the language around this. I realize we're getting into wordsmithing. Dr. Brooks.
Yeah, a few comments. First, I agree with should be administered because if there is a high-risk exposure, you consider, vaccinating. No, if there's a clear high-risk exposure, you should administer vaccine. But two questions. One is, and this is a general question, it is not licensed under 18, so if there's an issue, is it covered by the Vaccine Injury Compensation Act? And that is one question. And the other, I'm not clear on the guidance for those 18 and older. I don't know if it was explicitly shown in these slides. I saw it said we should vaccinate those 18 and older. But I didn't see any definition of who to high risk, who gets vaccinated, who is at high risk. It's not everyone, obviously. So did I just miss that?
Yeah, so during the February ACIP meeting, the vote was voted on for future outbreaks if the public health, if the outbreak specific guidance indicates that they should, then they should. Is basically what it is saying. So it's the
guidance based on the outbreak.
Yeah. So it's like
who's at high risk.
Yeah. So it's ACIP saying that if guidance at the time of an outbreak indicates that people should be vaccinated, ACIP thinks they should be vaccinated.
Okay. All right. And then that goes back into the Vaccine Injury Compensation Act question.
Yeah, Dr. Grimes, I see you're on. Are you able to comment?
Sure. Can you repeat that question, please?
Off-label use of a vaccine, is it covered by the Vaccine Injury Compensation Act?
Dr. Grimes, the discussion is about use of JYNNEOS vaccine among children in the context of an outbreak.
Right.
And so my guess is this is covered under the CICP rather than the VICP, but hoped you could.
Absolutely. Yeah. Thank you. So the Countermeasures Injury Compensation Program covers JYNNEOS and ACAM 2000 and other countermeasures that are deployed in response to smallpox and other orthopox viruses, which includes Mpox. So National Vaccine Injury Compensation Program coverage, or VICP coverage, is not under or does not oversee the Mpox countermeasures or vaccines.
Can I ask if there is not an outbreak declared, is there a gap for off-label use in that instance?
Thank you for that question. So for the CICP, it's based on PrEP Act declarations that are issued. Those PrEP Act declarations typically are renewed. So there has been a PrEP Act declaration for over a decade for smallpox and other orthopox viruses. So those continue to be covered. Now, in the event that there was a expiration of a PrEP Act declaration, then there would be a potential coverage lapse.
Okay, thank you. We will hope it doesn't expire. All right. Any other questions? I think we'll move on to our last presentation of this session, which is Dr. Rao again on considerations for long-term protection against monkeypox.
Thank you. So we're shifting now in this presentation. The last presentation was about just in general outbreaks, not specific to the one that we're currently experiencing. We're shifting back to just talking about the current outbreak. So over the last several months, CDC has received multiple inquiries about whether additional JYNNEOS doses will be recommended for people who were vaccinated against Mpox last year. There's limited data to inform decisions about this, and for that reason, we're not presenting it for an ACIP vote. However, we've been thinking through the available data and discussed it with the work group as well. And the purpose of this presentation is to convey our thinking about this important question that we're receiving very frequently. Next slide. So in terms of data, there are 2 CDC collaborations for which we have data about the serologic response after JYNNEOS vaccines. Next. The first is a study we call the DRC study and was launched in 2017 in the Democratic Republic of Congo, so 5 years before the global Mpox outbreak began. It involves vaccinations provided to healthcare personnel in the Choapa province of the Democratic Republic of Congo and was launched as a collaborative effort between CDC and the DRC Ministry of Health and the Kinshasa School of Public Health. Next. The second is a study we call the DC PEP++ study, and it involves MSM in Washington, D.C. with behaviors that increase risk for Mpox. And this study was launched in collaboration with the D.C. Public Health at the start of the global outbreak. Next. Because these studies set out to evaluate the humoral response of JYNNEOS, the DRC study also evaluates safety and effectiveness. Both studies are ongoing, but next. Because the DRC study began 5 years before the global outbreak, we have more real-world data. The DRC study also involves more study participants than the DC PEP++ study. Next. So in the next few slides, I'm going to focus on the data from the first 2 years of the DRC study. The data from the DC PEP++ study is preliminary, but it seems to indicate the same thing as the DRC study right at this time. So I'll focus on the DRC study. So in that study, serum was obtained at various time points over the 2-year time period. Next. Serum specimens were tested for the presence of orthopox virus-specific IgG antibody using an enzyme-linked immunosorbent assay, or ELISA, and positivity was determined by optical density, or OD, minus cutoff value, or COV, which is shown on these graphs to the right and the y-axis. So the graphs to the right show the level of antibody by days from JYNNEOS dose 1. The first graph is for persons who received no previous orthopox virus vaccine, and the second is for persons who received prior vaccination. And those prior vaccinations were not with JYNNEOS. It was childhood vaccine, probably something similar to ACAM 2000 or Dryvax vaccine. And that is a live virus vaccine, a replicating virus vaccine, so different from JYNNEOS. You can see from these that circulating IgG levels peaked slower and lower in persons who received no previous orthopox virus vaccine, and circulating IgG levels stayed higher for a longer period of time in persons who were previously vaccinated. So people might conclude that an extra dose of JYNNEOS could, through extrapolation of this data, be beneficial. However, there's no correlative protection for us to understand the significance of the higher antibody levels among people who had the childhood vaccination with a replicating virus vaccine. Next slide. And in fact, we've already presented data to the ACIP when the it was during 2021 when the ACIP was considering the use of JYNNEOS in persons at occupational risk for orthopox virus exposures. We presented data that showed that an anamnestic response was elicited when a JYNNEOS booster dose was administered 2 years after the 2-dose JYNNEOS series. So there is an ACIP recommendation that a booster dose with JYNNEOS be administered every 2 years for those with sustained occupational risk of exposure to variola virus and MPXV. But that was involved people who were working with research-grade virus, and it lumped variola virus into the same category of people working, the virus that people are working with. And we know that variola virus is the causative agent of smallpox. We know it's highly virulent, causes significant morbidity and mortality. The standard of care for persons at occupational risk of orthopox viruses has always been an ACIP booster dose recommendation. And the booster frequency was the only thing that was being truly discussed by the work group. It was decided on 2 weeks, even though ACAM 2000 is recommended every 2 years, even though ACIP is the ACAM 2000 is recommended every 3 years, because there is only data about about a potential anamnestic response for up to 2 years after the 2-dose series. We just do not have data for a time point after that, but if there was data to indicate an anamnestic response, then that would have been proposed. Next slide. So the work group concluded from this that the significance of waning circulating antibody levels is unknown. An anamnestic response is elicited 2 years after the JYNNEOS primary series, so it might not be clinically significant. ACIP recommendations for persons at occupational risk for orthopox viruses was for different exposures than those experienced during the current outbreak. It was for people working with research-grade viruses, and so we can't assume that the same recommendation would be applied for any patients in the current outbreak, and cannot assume that patients during the current outbreak all patients would need a booster dose. Next slide. We then looked at vaccine effectiveness data during the current outbreak to understand further whether what we are seeing in terms of infections after the 2-dose series. And as Dr. Minhaj has already mentioned, there are 3 VE studies that we've been evaluating, and the VE has ranged for a first dose between 36 and 75%, and for a second dose, 66 to 89%. Mpox cases among persons who have received 2 doses have occurred, and this is expected. Vaccines don't prevent 100% of illnesses usually. And these have been reported as early as August 2022. So they've been occurring since the start of this outbreak, really, that there have been some cases that have occurred among people who have received 2 doses of the JYNNEOS vaccine. And the 2023 Chicago cluster is what raised this alarm a little bit more. People were concerned that this cluster, since it was occurring mostly among people who received 2 doses of the JYNNEOS vaccine, that perhaps it implied that the vaccine would benefit from an additional dose. But we're not seeing any other U.S. clusters of a similar size, let alone involving this many vaccinated persons. And then just as a reminder, the Chicago cluster, while we're still trying to understand the reason for it, there were no hospitalizations among the people who received 2 doses of the vaccine. They were not typically prescribed pain control medications. The sequences are typical of the B.1 variant of the MPXV clade 2B, and no mutations that would confer increased pathogenicity were observed. Next slide. So the work group's interpretation of this data is that a 3rd dose is currently not indicated for the entire population eligible for vaccination. And they turned the focus to persons who might have severe manifestations from Mpox. Next slide. So as Dr. Sanchez has presented, persons with advanced HIV have had the more severe manifestations of Mpox and even died from uncontrolled viral replication. For this reason, the work group focused on whether there's any data about the use of an additional dose in people who are immunocompromised, particularly those with advanced HIV. We sought out all available data, including unpublished data, data involving very few cases, just anything at all to help inform our considerations. Next slide. So this slide shows first our considerations about the safety of a 3rd dose. So the current knowledge is based on 2 things. On this slide, we see the data from the same DRC study that I've been discussing that evaluated effectiveness. It also evaluated safety. So that study involves HCP, and it shows, as you can see in the graph at the bottom, increased adverse events among recipients of a 3rd dose that was given at 5 years after the primary series. So these are individuals who had already received the 1st and the 2nd dose. They received a 3rd dose 5 years later, and safety and effectiveness were evaluated. Now that 3rd dose was given to a subset of the patients. It was given to 170 patients, while the 1st and the 2nd doses were given to 706 patients. But you can see from the figure here, that the percentage of people who experienced some of these adverse events was much higher for those who received a third dose than for those who received a first or a second dose. A limitation of the study, though, is that it was performed in the DRC, and we do not know if if the findings can be extrapolated to the US population. Next slide. So we tried to look to see whether there was additional data about safety, specifically in HIV patients. And what we know is that a study of persons with HIV was CD4 counts 100 to 500, showed some increased adverse events, but not as significant among recipients of a third dose. And that third dose was given at 12 weeks. The limitation here, however, is that a very small number of total subjects received a third dose. Only 30 patients received that third dose, so it's difficult to know the likelihood of an increased adverse event among persons with HIV. We also don't have data about persons with an HIV CD4 count less than 100. So next slide. So the work group thought that this means that there could be more adverse events associated with a third dose, and that this could end up deterring some persons who have not yet received their first or second dose to receive those doses if they hear that a third dose is resulting in increased adverse events. Next slide. The work group then considered the serologic response data that we have about the response among persons with HIV compared to people who do not have HIV. There is data from 2 studies about this. So for nearly 600 persons combined between these studies with a CD4 count greater than 200, serologic response to the 2-dose series was equivalent to response in persons without HIV. And the figure here on this slide is just from one of these papers, but both of these papers show this data. I'm not sure why it's not showing up here, actually. Next slide. Perhaps it's, yeah, there it is. So this is from one of those papers, but both studies are showing the same thing. The limitation, though, is that there's no assessment of serologic response for persons with a CD4 count less than 100. Next slide. And then we also looked at serologic response to JYNNEOS among persons with HIV who get that third dose. And for persons with a CD4 count 100 to 500 and a lifetime nadir less than 200, serologic response of 3 doses is similar to 2 doses. And we also reviewed unpublished data. So there was no, we're not presenting that data here, but we received unpublished data from Bavarian Nordic, the product sponsor, for a very few number of patients. And there was no correlation by our read between low CD4 count and antibodies after vaccine. It was a very small number of patients, but that was our conclusion from that data. Now, in terms of limitations, there's again no serological correlate of protective immunity, and there's a small number of subjects that were included in this third image here. So under BD group, that would be booster dose group or third dose group, and there were only 26 subjects included in that group. So it's hard to make any clear conclusions from that. Next slide. And the Dr. Minhaj has presented the real-world experience with the JYNNEOS vaccine and showed the data that we have for VE in immunocompromised patients. So the VE point estimate for persons who are immunocompromised is lower than for the general population of vaccinated persons for both 1 and 2 doses, but the estimates do not differ statistically from estimates for the general population. There were few persons for whom this was evaluated, and the confidence intervals were really wide. And then I'll also point out that this data, immunocompromised status, was something that was self-reported by patients, and so it is unclear how many of these patients might have HIV but have well-controlled HIV versus those who have advanced HIV. Next slide. The severity of infections among fully vaccinated people, understanding whether or not these are occurring was something that we wanted to focus on, people after a 2-dose series who develop Mpox. And we looked at national reporting and also anecdotal reports. The current knowledge is that perhaps over 10,000 people have received Mpox. Mpox cases have occurred among persons with HIV, but we have no confirmed reports of severe Mpox illness after the 2-dose vaccine series. The CDC reviewed data reported from health departments for people who received 2 doses of the vaccine and confirmed none were hospitalized due to severe manifestations of Mpox. We actually did spend some time contacting health departments for those places, for those cases for which the information indicated that the person had Mpox, received 2 doses of vaccine, and there was a hospitalization indicated. And when we contacted those health departments, they confirmed to us that these hospitalizations were not due to Mpox. In one case, for example, due to housing instability, some other issues, treatment for an STI, concurrent STI, they confirmed they were not due to the actual Mpox infection. But I will say that anecdotally, we've heard that that there was a severe case in a patient who did receive 2 doses of the vaccine. We have no details about that case, though. We've only heard that from a provider who mentioned that they cared for such a patient. And I can also say that we were also contacted by a provider who is caring for a patient with severe immunocompromise who feels that their illness, while appearing necrotic in appearance, the lesions were not disseminated. They were localized to small areas. The patient was managed in the outpatient setting, and the clinical team felt that perhaps the severity of the illness was attenuated by the fact that that they received 2 doses of the vaccine. So there are limitations to this. This data was extrapolated from surveillance and consultation data. There's been no formal review of electronic health records linked to vaccine registries. And another limitation, though, is that it's not even known whether persons who do not respond to 2 doses of the JYNNEOS vaccine would even respond to a 3rd dose of the vaccine. So we're not sure what benefit would be provided by even proposing a 3rd dose of the vaccine. Next slide. So the work group concluded that there's no convincing data to indicate patients with moderate to severe immunocompromise would benefit from an additional dose of the JYNNEOS vaccine. Next slide. I will show you, though, that the work group was regularly coming back to the fact that there are very few 2 doses in general that have been administered in the United States. So the 2-dose vaccine coverage is only 22.7%. And the work group, some work group members specifically said that needs to be emphasized a lot, and that perhaps we should be emphasizing that rather than considering an additional dose of the vaccine. The work group did go around and around on this. There was a lot of work group meetings dedicated to this. There were at least 3 or 4 meetings when we ended up discussing this issue of whether an additional dose of the vaccine makes sense. And there was a wide variety of things that came up. Some people thought, well, what's the harm in an additional dose other than the data that we have from the DRC? But then others, and it became a louder voice from the others, but the others were saying more is not necessarily better. We don't have data to indicate that an additional dose is beneficial. We don't have data to indicate that severe infections are occurring among people who receive 2 doses via our CDC consultation service, or the data that we have available to us right now. And although an additional dose of a vaccine is sometimes recommended for immunocompromised patients, there's typically data to support that. Next slide. Next slide. So the work group's conclusions were that they were preferring that there be no CDC recommendation for a 3rd JYNNEOS dose at this time, including for persons with advanced HIV or other severe immunocompromise. And they emphasized several strategies instead, encouraging the 2-dose vaccinations among persons who do not have immunity, that is persons, for example, who have not had Mpox, so persons who have not had Mpox and also have not received vaccinations. And they also said that we need to remind people that they can prevent or minimize life-threatening manifestations through optimizing immune function, example through HIV antiretrovirals, ideally before there is an Mpox exposure. So if you can find people to give them an extra dose of the vaccine, similarly, you should be able to find people to optimize immune function. And then they also, if someone were to develop severe manifestations of Mpox, regardless of whether it's after a vaccination or not, we do have CDC interim treatment considerations that were published in March of this year about how to manage patients with or at risk of severe manifestations of Mpox that describes how to use the medical countermeasures that are stockpiled by the U.S. government and how to consult CDC for 24/7 consultations. And all of these things might help prevent severe infections and should be considered in combination with vaccines. Next slide. So in terms of next steps, we are at CDC continue to collect and evaluate any existing data. Like I mentioned, there's a lot of data about very small number of patients that we've been reviewing, particularly about use of JYNNEOS in immunocompromised patients. There's very little data, though. And we are planning to attempt to characterize the severity of Mpox cases experienced by people who received 2 JYNNEOS doses. Now, that can be really time-consuming and involve a lot of work from health departments as well. So, but we did find it reassuring that our consultation service has not received any such consultations, even though we have received consultations about patients who have not received any doses of the vaccine and have uncontrolled viral replication, and also the Chicago cluster, which indicates that none of the patients who received 2 doses had what seems like severe illness. We are continuing the ongoing VE studies, and if there is a change to the thought process here on whether an additional dose of the vaccine should be given, then that would be updated in the CDC interim clinical considerations. We are continuing to discuss this at CDC. Next slide. And I want to thank all the people on this slide who helped with so many aspects of this presentation. There's just been a lot of thinking that's gone into this, a lot of offline sort of conversations with various people, and a lot of input from the ACIP Mpox workgroup members who represent the Infectious Disease Society of America, AAP, CSTE, just a lot of different stakeholders that we ensured we heard from when we were considering this important topic. And next slide. Thank you.
Thank you. The presentation is now open for questions, and we have Dr. Cotton.
Good morning. Camille Cotton in Boston. So I am interested in the recommendation about the immunocompromised patients. It sounds as though that recommendation is somewhat more focused on patients with HIV who might be able to have HIV management enhanced, et cetera. But for many people with moderate to severe immunocompromise, it's possible that they actually can't have their net state of immune suppression improved upon patients that might be on rituximab, other highly immunocompromised patients. So I'm wondering if there would be thought about some softening of an additional dose of vaccine. You know, in the COVID guidance, it's actually stated on a case-by-case basis, providers caring for these patients may administer an additional dose of vaccine outside of the FDA and CDC dosing intervals when, based on their clinical judgment, the benefits of vaccination are deemed to outweigh the potential and unknown risks for the recipient who is immunocompromised. And I do think it would be helpful to clinicians in the field who are managing these patients to have some flexibility with an additional dose. I do agree that, you know, it's hard to know given the lack of data, but we also know that some people in our clinical estimation might benefit from an additional dose, especially if one of the prior doses was given in the setting of significant immunosuppression. Thank you.
Yeah, thanks, Dr. Cotton. Yeah, that's helpful information. Thanks for mentioning it. I guess I'll just add a few pieces of information in case they're helpful. The patient that I was referring to, and again, this is not published. I just want to say that the patient I said who had an attenuated illness was an individual who was not immunocompromised from advanced HIV, but was rather post-transplant and seemed to have an attenuated illness after 2 doses of the vaccine. At least that was the thought process of the providing clinicians. But also, we have not consulted on any, we've consulted on a very, very few patients who did not have advanced HIV. So the immunocompromised was advanced HIV, I think, except for two maybe patients. And they had not received any doses of the vaccine, the 2 people who did not have HIV as their immunocompromising condition. So it seems that for this particular outbreak, advanced HIV is the most common immunocompromising condition that is occurring. And one work group member said that their concern was that if it was like a permissive recommendation, that it would confuse clinicians. And so I guess I'm just wondering your thoughts. She thought that it might make people think, oh, should I call back all my patients then and give them, if they have a CD4 count less than 200, an additional dose? And so this is one person, just said it would be good to land on either recommending or not recommending. But yeah, I just was wondering if you had any comment on that.
Well, so I think, you know, I think that this guidance in the COVID vaccine guidance is super helpful, at least to me and my colleagues. But on a case-by-case basis, providers caring for these patients may administer an additional dose. That to me is not call back everybody within a certain cohort of CD4 counts or whatever, but on a case-by-case basis. I'm just saying that it is true that I think you will see moderately to severely immunocompromised at lower rates in this population compared to perhaps people living with HIV. But that being said, it would be helpful for this population to have the capacity to give an additional dose of vaccine. I think the wording on a case-by-case basis means that we have some flexibility, because right now I don't have any flexibility. And I do have patients who, understanding the risk of disease and their concern that they could have life-threatening disease, changed some of their habits. But now moving forward, now that we're really away from the time of intense disease activity, I do worry that they could be at risk, especially the further we get away from vaccination. We know that vaccine protection wanes more rapidly in immunocompromised. So I agree that we should not make soft recommendations that are unclear, but I think on a case-by-case basis, providers caring for these patients may administer an additional dose when, based on their clinical judgment, the benefit of vaccination are deemed to outweigh the potential risks. So I would just advocate fairly strongly for that.
Thank you.
We'll have Dr. Paling, Dr. Talbot, and then Dr. Bell.
So, Dr. Rao, first of all, I want to say thank you for an outstanding presentation, and a special thank you to all members of the work group who've really wrestled with a lot of challenging informations, and all persons in public health and the CDC that are working on this Mpox outbreak. I wanted to underscore a point that you made that I thought was really valuable. And if I did my math correctly, I believe that it was about 62% of people who initiated their JYNNEOS vaccine had actually completed it. And so that does underscore the need to make sure everybody who has initiated the series does get full protection. Thank you.
Dr. Talbot?
Yeah, I was also going to highlight something that you said. Vaccines are one form of prevention. And when we do preventive measures, we usually put multiple ones in place. So this is just a shout out, once again, for condoms. Thank you.
Dr. Bell?
Thank you. I just wanted to go back to Dr. Cotton's suggestion and say that I think she's making an excellent point, that there was a lot of thought put into the wording for the COVID-19 vaccine statement with respect to immunocompromised people, and a certain amount of flexibility on a case-by-case basis. And I think that, Dr. Rao, it would be important for us to take her experience and feedback into account. And I think that, what the suggestion she's making is a reasonable one.
Thank you. Thank you for the input. Really appreciate it.
Any additional questions? Well, I'm just going to offer that going back, I'm now scanning the website again and looking through. So let me just say there's a tremendous amount of information on monkeypox available from CDC, and it's really incredibly detailed. I think that as the guidance and the information continues to expand, what might be helpful is sort of the integration and harmonization, because just thinking about the pediatric question, I'm looking in several different places, and I think that perhaps just an opportunity to say, like, if you have a population in front of you, understand what their risk is. So what's their risk of exposure? What's the risk of severe disease? And then here are the opportunities. And I do think perhaps taking a look at that and integrating it in and providing that full context might be helpful, because I think it's very situationally dependent. Like, here's an outbreak, you're a healthcare worker, but just giving people the intuition and consolidating it perhaps at this point might be really helpful for many of us who are just trying to implement on the front line. Anything else? but just an incredible amount of work. Let me just say, like, it's unbelievable how much work the team has put into monkeypox. And, you know, obviously, as Dr. Talbot said, not just vaccines, but the entire cascade of diagnosis, treatment, and management of patients. And, you know, just thank you for all the work that you've done.
Thank you. Thank you to all of the people who at CDC who have deployed and helped with this response. It's definitely been a team effort and wouldn't have been possible otherwise. Thanks.
Dr. Long, last word.
Yes, I certainly agree with your conclusion that for the general group at risk, a third dose is not indicated. And you know, what you know about what looked like a significant boost for those who'd been previously vaccinated, they were not previously vaccinated with the same vaccine. So for live virus vaccines, a second dose should not have much effect if the first dose worked, because the virus has to grow up and make elicit the immune response. So we know, for instance, for measles, the second dose is mainly to be sure you got one that worked, and after that, it's not beneficial to give more because you preclude the replication. Now, it might be different for monkeypox, but it might also be different that the second dose of the same vaccine doesn't do as much as if it's heterogeneous, and a third dose might not do anything, and that would be okay too.
All right, with that, I think we will plan to close this session, thank our speakers today for their outstanding presentations, and go to break. So we'll take a 10-minute break and return at 15 minutes after the hour. Thank you, everyone.